we are now going to talk about innovative approaches in HIV care through community-based care. So I want to welcome Dr. Anna Mia Ekström, who is a professor in public health, HIV, at Karolinska, and she will talk about sustainability and effectiveness challenges in future large-scale HIV treatment in resource-poor settings.
I know some of the things that are in my presentation have already been covered in the morning, so I'll skip those, very fast and try to focus on a few things that I don't think have been covered so much so far. I work as an HIV clinician 1 day a week at Huddinge Hospital, and most of my research for the rest of the time is in East Africa, South Africa. So I think you've talked about this, and I wanted just to emphasize more about not the achievements we know very much about, more on what we have left to do, and I'll talk a bit more about that too, to how we can try to get more people on treatment and also stay adherent to treatment and improve retention in mother-to-child transmission programs, in prevention of mother-to-child transmission programs. We have a lot to do still. About half don't know their status, and the majority of women still drop out from mother-to-child transmission programs. So I know you've also talked about young girls, and here I wanted to share with you some of the research that we've been doing in terms of young women's risk behaviors and sexual networks. And I have several PhD students in South Africa who've interviewed young women, for example, at shebeens and sort of bars, on why still knowing, that HIV is quite prevalent in many of the townships, why they're still engaged in this high-risk behavior. And a lot obviously has to do with being young, when you don't you live for the day much more, and thinking that, okay, I might die when I'm 35 plus, doesn't really matter because life is pretty much not so interesting anyway. As an old person, you live much more for the day. And also the sort of lack of other sources of income, if you want some sort of cash on your pocket, transactional sex, I think you've mentioned that. The possibility to get a little bit of cash to refill your cell phone or to buy a new skirt or something is something that they sort of mention as a very important factor. They're obviously not sex workers, but transactional sex is an important part when you don't really have any other way of source of income, when your parents can't give you any pocket money, for example, and you're still in school. So one of the citations was that money talks, bullshit walks, and bullshit is HIV then. It's really not so much of an issue, even though it's very much known. And when we interviewed young men with multiple sexual partners in Karolinska, this network figure was created by one of my other previous PhD students, where men sort of really value their core sexual groups, or the core groups of friends, I should say, and had sexual networks which were organized from these core groups, which are the blue dots. And many had sort of more stable long-term girlfriends, maybe that what they had children with, and whom they also gave money regularly as sort of responsible fathers, but they also had other networks outside of the relationship, and much of this was sort of facilitated also through mobile phone networks. Of course, if someone in this network is newly infected, the infection will spread quite rapidly in this network. And also the women felt that when you interviewed women, then many of them knew that their partners had other partners, and they sort of felt, well, I don't want to be, I don't want to feel stupid and not have a backup if my partner sort of dumps me for somebody else. And also viewed this as being more and more liberated in modern women, that you choose your sexual partners the way men always have done. You don't sit around waiting to be picked up or selected, but you're also an active, sort of liberated, free woman, but obviously more vulnerable than to HIV infection. So talking then about the risk of the different difficulties in scaling up access to treatment. Obviously, we still struggle with lots of health system shortcomings, both in terms of stock out of HIV tests, but also in terms of the medication. So lots need still to be done to ensure regular access if we want adherence to be improved. And we need to make access much more easy out at the community level. And right now, for example, you need to refill every month, and that requires for some people a full day of going to the clinic, lining up, queuing, and once you actually get there, it's 40 degrees, Celsius. You have your children screaming next to you, or you have to take a full day off from work. You need to pay for transport. Once you get there, there's no medication. If you've done that 3 months in a row, you sort of get sick of it. Really. And also that you need to line up in front of an HIV-specific clinic is a problem, because you may be seen then if you have to stand there for hours by your neighbors, etc. So the lack of integration of HIV care into primary care, and the fact that you need to refill this medicine so often and go long distances to do so, is a big problem in terms of long-term adherence. So integration is very important, and also facilitating so that they can perhaps get medications for longer. In Sweden, we prescribe from 3 to 6 months, for example. But that, of course, requires a functioning drug distribution system where there are not regular stockouts. Right now, you might have so few drugs in stock, so you can't hand out more than a month at a time. So we really need the drug distribution system to work for the millions of people who need care. It's not just the staff, it's also really to look at these drug delivery systems. We've talked about adherence, and that so far less focus has been on long-term adherence. Much of the focus has really been on getting more people onto treatment. That's also what UNAIDS and many other organizations report, is the success in recruiting sort of new heads, new counts, while people who are retained in care is much less. There's much less focus on that, and usually you only measure the people who are still at the hospital, what their viral load is, etc. But all of those who've dropped out are sort of lost. A month ago or so, I was in Kenya, and one of the most successful clinics in Western Kenya had initiated 17,000 people on treatment in the last few years. But 5,000 of those had now dropped out, and nobody knew where they were. Many were children, obviously. So when they reported adherence, they only reported the adherence among those who remained in treatment. But a third had then dropped out, and might have sought care elsewhere, or obviously probably weren't virally suppressed. And so we have to, and there was no system really of linking mother-child pairs when moving from PMTCT programs into lifelong ART to make sure children and mothers weren't lost on the way. It was just, 2 buildings next to each other, but it's the typical thing again of integrating different sorts of HIV care and different sorts of care. It doesn't work. There was no electronic system, not even a paper record system linking the child to the mother, or making sure someone picked up if the child or the mother didn't show up at the sort of regular ART clinic. Nobody would know, and nobody would track them, because the PMTCT counselors were sort of really focused on their task, and the ART counselors were focused on their task. There was no one making sure this transfer worked, and that's a huge problem, really. And also the fact that, as we see that support people, lay counselors, or even outreach workers are being funding is being cut for them. Those are the ones that are really, really needed in terms of ensuring adherence. Because when you feel well and when you know the baby is safe, this is what mothers tell us, you sort of lose motivation a little bit to take the meds yourself as a woman. Because there's so much in your everyday life that you have to deal with. You need to make sure there's food on the table. You may not have food. You feel more dizzy when you take the drugs, etc., etc. So your focus, once you know your baby is safe, your focus and your motivation to take the medicine yourself declines. So we have a big problem of that in terms of PMTCT retention. And it relates to adherence. And this is a picture of, that I'm sure most of you know this, but the resistant virus is the blue spots, and the white spots is the drug susceptible virus, which is also called the wild type. So when you are on treatment, but when you have episodes of insufficient drug exposure due to stockouts, for example, or due to poor adherence for some reason, the resistant virus will accumulate in your body, and once you are put on ART again, it doesn't work as well. And this is a problem because we usually have access to first or second line treatment in many low, poor resource settings, but third line treatment is sort of the expensive different alternatives that we can offer in Sweden today aren't available and are way too expensive to offer. So this is from Nairobi. from the Kibera urban slum there, and just an example where we've done much research with AMREF. And one example, it's sort of easy to understand why you can't really take your drugs when you live in a shack like this, where if you haven't told your partners, for example, or your neighbors that you're positive, there's no way where to hide the actual drugs, and nobody wants to play with your children if they know they're positive or that they have a positive mother. So disclosure is a huge issue, and also I'm just thinking about when you have a community health worker there, if it's someone of your neighbors, the gossip going around is a big risk, really. So in terms of, and I think it's not something that's talked so much about, disclosure and confidentiality issues with community health workers who may have 2 weeks of training or a few months of training at the best. Confidentiality may not be the first priority, really. So many patients didn't feel comfortable knowing that their neighbor was a community health worker that would come to their house every day. Everybody knows everybody. They know if this person drops by every month or every week, then everyone knows you're positive. And then you may be an outcast. Stigma is still that high, and nobody wants to be with you or your kids. So many women and men choose not to stay adherent because of the risk of being unwanted disclosure in the neighborhood, which is a problem that we really need to deal with. It's difficult. So this is also why retention in care. Once you know your child is safe, the retention is the dropout from PMTCT is quite high. You struggle when you know that you have to, but then when you can relax, when you know the baby is negative, or your motivation to stay on treatment is much lower. So we see that actually a minority bring their children back for testing. At 2 months already, the dropout from this PMTCT schedule is quite high, and it goes on like that. And very, very few continue the full breastfeeding period and bring their children back for final testing at 18 or 24 months, when the final visit is supposed to happen. And this is some result of that. This is a picture from the Rakai Orphan AIDS orphanage, where in a small fishing village we had several hundred children being AIDS orphans, and the PMTCT clinic was empty. There were no staff working anymore after the handover from the research institution to the Ministry of Health. The prevalence among the bar girls, who was the main occupation among women in this extremely high risk fishing village, was really many worked to sell sex, and the HIV prevalence was around 40%. So here, PMTCT should have worked extremely well, because everyone was like 2 minutes walking distance from the clinic. ARVs were free of charge. People were informed about HIV. It still didn't work. So this is a big challenge. It's just not the medicines. It really needs to be, information needs to be repeated. They need to find really an incentive to do this and to retain. And for that, I think we need lots of counselors and supportive people. I think you've touched upon this a bit, so I'll skip this. Going then to community-based approaches, a few weeks ago I was in Cape Town and visited the Desmond Tutu Foundation's Teen Track, which I thought was an excellent example of outreach. It's an example of outreach where you have this truck which looks sort of attractive. It stops at the townships, and it offers, you can braid your hair, you can check your email, you can get a health checkup, you can check your blood pressure, if you have diabetes, listen to music, meet your friends, but they can also have an HIV test and get counseling. So I thought that's sort of an innovative, interesting approach to how you can reach young people and make it more attractive. This is now a South African setting, but I think similar things could be done also in East African settings too. We also know that self-testing is being tried with very good results. Also in Cape Town, they have also Desmond Tutu Foundation has initiated. You can get a motorcycle delivery. You order your HIV test on the web, and a guy comes and delivers it at your door. And then you get tested, and then there's a follow-up. There's sort of a signal to the foundation that we've sold this test, and you hope that this person then will contact them, and there's a follow-up of the positive ones afterwards. So there's been a lot of worry. I think at least in Sweden, we think that people will go and commit suicide immediately if they test at home. So there's no way we would want to try this here. But if it works in other countries, it might actually work here. The number of people are more aware. It might work. It's still a way to reach those that we don't reach with our normal outreach. So it's a way of reaching the periphery, those that we still haven't reached, and which is about 17 out of the 37 million people living with HIV. We must find new ways of reaching them. And we know that door-to-door testing, it really increases more. It reaches first-time testers, people who haven't tested it before, and people with higher CD4 counts, where we can go in and use treatment as prevention more effectively. And it leads to a greater uptake of testing and linkage to care. How much time do I have? Nothing.
Well, you're already 1 minute past your time. So you need to
I need
do
to
your
sum
summary.
up.
Yeah.
Okay. So this is just showing that with the household testing only, is the light green things, and the status quo is the darker. So we really see that the additional things, both in terms of ART initiation threshold, higher CD4 counts, the number of people taking up testing, and the people who stay adherent to ART increases with household counseling and testing. This is a study from South Africa. So I think I will just go to this thing then, the last thing. We really need to do something more about the stigma, because now we know that the medicine works. The medical problem, to a large extent, the medicines are fantastic, miracle drugs. They're as close to cure as we can come. We know that people can live a long life without affecting your partner, your child, and there are very little side effects. The medical bit is almost solved, I would say. What we have to deal with now is stigma and the solution in terms of health systems to sustain this long term. And this is just to let you know that the study has been performed in Sweden, the biggest so far, on quality of life, and it's going to be released tomorrow afternoon at HIV Sweden. And it shows that the Swedish people living in Sweden, where obviously more than half have been born abroad, but they live in Sweden, are now average 7 out of 10 on a quality of life scale. So quality of life is extremely good, except in terms of sex life, where 1 in 4 has stopped having sex after being diagnosed with HIV, and this is all due to stigma. It's nothing to do with medical problems or anything like that. It's all due to the fact that they know more than their potential partners. The society doesn't know how good the HIV medication is, and that you can't transmit the virus to your partner when you're on your ARVs. And if everybody knew that, stigma would be much, much, much lower. So I think that's our main task, to bring that message out. This fantastic treatment makes you, prevents you from infecting your partner, and then life would be so much easier. Thank you.